let's start with volume control. So we're gonna do so as usual, we're gonna do set parameters, dependent parameters, and waveform. Volume control is called VCV, volume controlled ventilation. Some people call it AC, but I like to call it VCV because AC reminds me of the old mode that we talked about yesterday that had all kind of problems with it. So the set parameters are tidal volume, respiratory rate, FiO2, and P. The dependent parameters are peak inspiratory pressure, plateau pressure, and respiratory rate. Like we talked about, it was similar to what we talked about in AC. The waveform, it's almost a review of the AC without the breath taking. So you have a pressure waveform, looks like a breath like this, and the second breath looks like this, and this breath looks like this, right? This is the controlled breath, and this is the assisted breath. That's why we call it, some people call it assist control, or the new assist control. This is assisted obviously because there's an effort to breathe before it. And the flow waveform is like this. Okay? As we talked before, we said the maximum pressure is reached towards the end of the breath because it's a volume delivered breath, so it keeps on giving the volume until the lung is completely full, and then the pressure is max. And the maximum flow is reached in the middle of the breath, and remember that when we compare it to pressure control. The maximum flow is reached around the middle of the breath, where basically the flow accelerates until it reaches to a max, and then when it reaches, after it reaches the max, the lung is already half full, so you can't, you have to, the flow has to decelerate a little bit. And the exhalation is always looks like this in all modes of ventilation. So the respiratory therapist sets two other parameters, but they don't tell us. They don't require an order for it. One of them is called sensitivity, and the other one is called flow. And the sensitivity is how sensitive the vent is to your effort to breathe. So how much negative pressure, for example, you need to produce here for the vent to say, aha, that guy wants to breathe now. So it used to be -2 centimeters of water. So it used to be pressure triggering was -2 centimeters of water, but that caused a huge problem with COPD patients. For COPD patients, when I was young, they used to say COPDers, once intubated, always intubated. So don't intubate the COPD patients. But that was kind of weird. I never understood that 100% because why would that happen? Especially if I'm doing anesthesia residency, huh? So that means, and I asked my attendings, it's like, so that means if I intubate somebody that's coming in for toenail amputation, and I want to extubate him at the end of the surgery in half an hour, I can't? Like, something will change that much inside the patient. He won't be able to breathe on his own when he walked into the hospital? And one of them told me, yes. I said, why? How? She said, because of the cuff of the endotracheal tube with interrupt ciliary motion and all of this bullshit. That is like, people are trying to make a reason for it, but the reason it wasn't that. The reason was bad interaction between the patient and the vent, but nobody knew it at that time. When I was towards my third year, I did my whatever, considered a sub-I in the ICU or something, but my attending, who was very, very, very smart, he would come and say, we would tell him, we can't extubate the COPD. Every time we wake him up, put him on some breathing, some sort of a pressure support trial, he would become very agitated. So, and this coordinated with the vent and tachypnic and fails. So he says, I don't know why, don't ask me why, but just put him on TPs. The TPs, if you remember from yesterday, this is the corrugated tubing that goes from the wall and then the endotracheal tube is here. So basically the oxygen just keeps flowing by like this, and the patient just sucks in air through the endotracheal tube. So basically taking the patient off the vent. You're taking the patient off the vent. And it works. And we're like, wow, he's a magician. Wow. Abracadabra. He doesn't know, we don't know, and nobody knew. And at the same time, by the way, if you look in the 90s, back in the 90s, there was multiple pieces of, multiple publications showing that T-piece weaning is better than vent weaning. Also, nobody knew why. But when I went to the Brigham, they actually, at that time, you know, it was discovered what's the problem here with COPD. So let's say you're starting at 5 of PEEP, okay? And if your PEEP starting at 5, then the vent is gonna have to trigger at 3, right? Because you're saying -2, so if the patient takes a breath that big like this, it gets a breath. The machine gives it a breath, 500 cc or something. But imagine that you are, if the patient is COPD and have auto PEEP, and the auto PEEP will be like, let's say the auto PEEP is like 12 auto PEEP. So that means the patient has to go from 12 all the way down to 3, like 8 or something, 9, for the machine to understand that this, he wants a breath and he gets a breath like this. But of course, this doesn't happen all the time. It happens every once in a while. You know, the patient can take -12. People can take -12. It's not a big deal, but they can't take it all the time. That means for them they're breathing fast all the time or breathing hard all the time. So you start doing like this, which is non-triggered breath. Non-triggered breath. People just once you start having a couple of non-triggered breaths, the patient feels very uncomfortable because it feels that he's suffocating. So that's why they failed on, and COPD patients failed on the vent. It wasn't that they're having any issues, physiologic problem with their lungs. It's just the interaction between them and the vent. So at that time, what we used to do, we used to paralyze the patient briefly and measure the auto PEEP and match the auto PEEP. So if you talk to some of the old pulmonologists, they'll tell you, did you match the PEEP? You know, did you match the PEEP? Okay, well, this is old. This doesn't happen anymore. So anyway, so we used to match the PEEP, giving like PEEP of 12, and that fools the vent to think that we should trigger at 10. So the patient will be comfortable. Now, about 10 years ago, or even more than 10 years ago, they switched, or all the companies found that this is a problem, so they switched to flow triggering. And flow triggering is -2 liters per minute. So now it doesn't depend on the pressure. It depends on the flow. So it doesn't matter where you are on the pressure curve, as long as you can deflect a certain flow in a negative direction, then you're good. And that requires that all the vents now have something called the bias flow, BIAS flow, bias, which means that like 70 cc's a minute, something like that, which is just allow the patient to do like this, and that, you know, the vent recognize it. So that makes it much easier, made actually COPDers easy to intubate and extubate, no big deal here. But the -2 liters per minute can be too much for some people, which is patients are very, very weak, and for that reason we have to drop it to -1. And these patients are Guillain-Barré syndrome, polio, all of those people, right? Critical care myopathy. You're not going to extubate them obviously, but they probably need to be trached, and to be comfortable and awake, you have to decrease the triggering to -1. It can also be too little for patients with hiccups. Patients with intractable hiccups, for example, can get like 80 breaths per minute and then seize. So we don't want to do that, so we can go up to -10 or -20. It can, and a lot of other things can trigger the vent. Water condensation. You know, if you're using water for condensation, we used to use a lot of water before. If it puddles in the lower part of the tube, can actually move a little bit and trigger the vent. Sometimes abdominal movement. We had a patient who was pronounced brain dead, right? So brain dead is not breathing. And then like organ bank is coming, trying to take his organs, all of these things, and then the nurse told me, he's breathing at 50. He breathed. It's a resurrection. Anyway, So we go in the room, and I was puzzled. What's going on? I was like scared because I could see my career is disappearing in front of us. The Boston Globe is gonna put out there a miracle in the South. Anyway, so we look and we find that that's exactly his heart rate. So his heart rate, he was thin, and his heart is like beating so hard, so it actually changes the pressure inside his chest, and so we went -10. Another one after a bronch, the lady was taking a breath of 105 breaths per minute after a bronch. So we didn't know what to do. So I said, "Give me the paralytic." So I got the paralytic. Still 105. Still breathing at 105. So it's not her. Something else is happening. So it could be that something is like a ball valve type thing, or some secretion at the endotracheal tube level or something. We didn't know what it is. So all what we did, we just kept on increasing the flow triggering until, and it still didn't stop until we stopped it completely. Like we turned it off. This capability, we don't have it in these vents, by the way, but at that time we used to have the capability to actually cancel it completely. And if you cancel the flow triggering, what would this mode become?
Like a pressure control?
No, well, it's still volume. You weren't there yesterday, but it will be CMV, controlled minute ventilation, which is the first mode of ventilation that doesn't recognize the patient at all, right? So that's what we did for a day, and then we extubated the patient the next day. The flow is basically how fast the breath is being given. So it's 40 to 100 liters per minute, and that's how it looks. So basically, it doesn't change the tidal volume, but it changes how fast the breath is being delivered. So for example, if I want to deliver 500 tidal volume they always start at 40, by the way, and then they titrate their way up. At 40, it looks like this. So 500 tidal volume at 40 liters per minute. Okay? If I want to do at 60 liters per minute, it will look like this. It will be delivered, the breath is shorter, the peak airway pressure is higher, and the majority of the breath is delivered earlier now. 80, it looks like this. 100 looks like this. Right, so you see the difference. Right, so based on what? What is the reason the respiratory therapists play with this and start at 40 and then keep going up? Why they do that?
Sometimes if you want to reduce the inspiratory time, if somebody with asthma or something like that.
Yep. So that's one of the two big reasons to do that. One of them is the patient is asthmatic. I can't take all the time for inspiration and leave him no time for exhalation, so let's reduce the time. Number two is air hunger. Air hunger is when the patient does like this, like moving all the the accessory muscles of inspiration every time the breath is being given. So that shouldn't be, right? Why are you taking a breath when the breath is being given? That is not normal. So that's why they do that. So who's the weakest link today?
Me.
Okay, good. So that's why you're gonna be asked the question. This is all flow waveforms. Okay, so what is this? How do you describe this type of breath? Like you walk in the room, you look at the flow waveform, which is the second waveform on the vent, and look, obviously you guys don't look at the waveform because it's right there, right? when I was a resident, there was no waveform. It was scary, professor. That's why we used to disconnect people all the time. Now we don't have to disconnect people all the time. And we were the respiratory therapists at night. There was no respiratory therapist. And that's a Bellevue hospital, big hospital in New York. So anyway, and there was no, so you have to look at the patient. There's no like feedback from the patient. You really have to like really listen to the patient and stuff like that. You give the vent, they're just like, and look, the vent looks like a piece of furniture, like huge like this. It's like, okay, let's take it off and just let's ventilate the patient. I don't know what's going on. But towards the third year of my residency, they actually bought one screen. One screen. So we find the sickest patient in the unit and put it on. And then when the patient gets better, we took the screen, put it on another patient. And they'll be like, whoa, we see inside the lung. Anyway, so it's very valuable. That's just the gist of the story. I had an imposter intensivist, a trauma surgeon who used to, think that he's an intensivist. So he would come to the room and, this is the vent behind. He's like, so what's the setup? It's like you can't. If you're an intensivist, your hands, you can't control your hand. It's like all doing like this on the vent. But anyway, what's happening here with the waveform?
It's a control.
Yes, that's the C. That's control. There's nothing happening behind it, and it just appeared like this. Okay, how about this one?
Assist.
Beautiful. And how about these two or three?
It's non-triggered.
Non-triggered breath. So either the patient is too weak, like Guillain-Barré syndrome, or he is COPD, and we rented a vent. Sometimes we rent old vents because we don't have an old vent is pressure control. So when or pressure triggering. So when the old vent comes in, if you see it going towards the COPD room, you tackle it. No, just push it to the ARDS room. It's better. Yeah. Okay. How about this one?
Final beat.
No. So this one is called. These three are called double triggering. This is called early double triggering, and these two are called late double triggering. The early double triggering, when the triggering happens, when the breath goes up like this, and then the patient is happy as long as the flow is going up, and then suddenly when the flow turns down a little bit, the patient doesn't like it. They say, no, I want more flow. So he does like this. That's the air hunger. So the early double triggering indicate air hunger, and the only treatment for it is to give the patient more flow to satisfy his air hunger. Right? So that's the air hunger we're talking about. You give 100 liters per minute. If you keep increasing until you reach to 100 liters per minute, and the patient is still air hungry, the only thing you can do is switch to pressure control because it gives you unlimited flow. Right? The late double triggering, these two are the same. But this one, the breath is a little bit shorter, this one. So basically, that means this doesn't happen a lot in volume control, it happens mainly in pressure control, and that means that the I time is too long, and the patient is too awake for it. So basically, I time is too long, you're holding the patient in inspiration, and against his will, so he wants to take another breath, whether here or here, and you're not allowing him, so he's actually forcing his way into the second breath, but because of the valves and is struggling with the pressure, he pulls out a smaller breath like this, and he becomes very uncomfortable, right? And very discoordinated with the vent, becomes like a vicious circle. And the vent actually counts these two as one. So if you count the vent pressure rate, it's gonna be one, that's one. So obviously, what you need to do is that you see if you need the I time, if you need that I time for oxygenation or something, paralyze the patient. If you don't need the I time, cut the I time, right? I have an intensivist who told me once that he fixed my patient. I said, how? He said the respiratory rate was 30, now his respiratory rate is 15. Sounds too good to be true. So I went to the vent, and this is what I've seen. He just prolonged the I time and swallowed the other breath, and it became 15. But the patient is still breathing at 30. Any questions about volume control?
Can you just explain quickly how did the top one was control and the second one